Dr. Vidyut Jain from Indore, cardiologist. I work in a Choitram Hospital and CSI Hospital as a cardiologist for almost 35 years or more. This afternoon, I had given a talk, particularly on the management of the acute coronary syndrome in this COVID pandemic time. We all realize we had a difficult time in last 1.5 years for all, whether the patient had an acute coronary syndrome or COVID disease or not. These patients, when they were not able to reach to the hospital earlier, they suffered a high mortality. And then when they started coming more and more because of the increased incidence of the acute coronary syndrome, which was occurring due to COVID itself, because COVID itself makes many patients vulnerable to plaque rupture, resulting into acute coronary occlusion and then myocardial infarction. Sometimes this patient can get into coronary artery spasm, and sometimes because many patients in a hypercoagulable state or prothrombotic state, which led to the occlusion of the blood supply to the vital part of the body, including heart. That led to myocardial infarction. These patients, when they were coming to the hospital, with a lot of confusion, how to get them into the hospital because there are no beds. Sometimes the patients were themselves in great fear. If they come to the hospital, they never knew whether they had COVID or not. So they were always feeling very shaky to get in hospital because they were worried about they will acquire COVID here. Now, some solution was always needed. A lot of discussion was there. Many conferences were held virtual, how to identify this patient in proper manner and then treat them as per the guideline, or some deviation of guideline was needed. So whenever the patient with acute MI come, there are 2 or 3 situations. One is situation acute STMI, that is acute ST elevation myocardial infarction, which is definitely a high risk situation. In this patient, all this patient ideally in every center is treated with primary percutaneous intervention and angioplasty. However, many patients who are coming for this particular indication, sometimes it was not possible due to overburdened hospital. Sometimes it was not feasible for them to get into the hospital. Sometimes it was not possible because many staff were not coming to the hospital. However, we must and we had done. Many patients were managed with primary PCI with acute coronary syndrome to reduce their morbidity and mortality and save them from the deadly problem of the death. Hence, all these patients who underwent coronary angioplasty with COVID positive or negative in acute COVID era, we must definitely assess them properly by doing routine cardiogram, echocardiogram, non-invasive, then invasive angiography. And simultaneously, we took all precautions to protect our staff and ourselves and patient relative. So nobody gets infection, at least in the hospital. Once the patient is stabilized, then they are shifted to the ICU and then later on to the usual hospital care. Then there was another situation like non-STMI, where there is no ST elevation. Some of these patients may be at high risk or very high risk. They were treated as like almost like STMI, means they were also offered treatment in the form of primary percutaneous intervention, or sometimes they were given fibrinolysis if needed, or then most of the patients were treated medically or medically managed. If they are worsening in between, then this patient was shifted to the acute coronary care unit and they were possibly treated with PCI. Then there was third situation. Patient basically were admitted only for COVID-19 respiratory problem, and suddenly they developed cardiac complication. And one of the cardiac complication was acute coronary syndrome. There it is very, very important because this patient are already sick from the respiratory point of view. So this patient should be assessed clinically and by all possible methods for what are their comorbidity, what is their oxygen level, what is their hypoxia, what is their sepsis level, then what is the hemodynamic status, what are arrhythmia, whether they are getting it or not, and whether the patient is in heart failure. Accordingly, they were managed, and these patients were also very, very high risk, but the treatment was again sometime angioplasty and sometime fibrinolysis and sometime only medical treatment. Having done all that, we did realize that these patients are ST elevation ischemic heart disease patient during COVID era posed a greater challenge to us. And a lot of confusion was there, but slowly we all learned from each other's experience and gradually we could achieve the success rate which was near to the non-COVID era. So, dear friends, I think you all have taken this challenge very well and you have managed your patient very well. And I think time will teach us many new things, and still our COVID era is not end. But anyway, we'll continue fighting with it. Thank you very much.